Good afternoon, ladies and gentlemen. Today, March 31st of the year 2021, we are presenting our session, our extraordinary session from the Mexican Association to Study Hematology. We are happy because we are linked to the Mexican Society of Aplastic Anemia. I would like to introduce President Dr. Magdalena Ortiz Sandoval, that in a few minutes will address us all with a welcoming speech. Also, I would like to introduce Dr. Sara Frías Vázquez, Dr. Blanche Alter, Dr. Carmen Sales Bonfin, and our good friend, Dr. Efren Montaño Figueroa, who is also Vice Chair of the Mexican Society of Aplastic Anemia. Everybody, thank you so much for dedicating your time, your capabilities, and that you are generous enough to share your expertise and knowledge. I want to thank you, especially every Latin America society that is joining us, and of course our members. Group of the Mexican Association for the Study of Hematology, and all of our guests. Thank you so much. Let's begin with this excellent session. This is a very important topic for all hematologists. Thank you. Good afternoon.
Hello, good afternoon. As every week, we are pleased to welcome you on this weekly meeting from the Mexican Group for the Study of Hematology. We are streaming from Mexico City and also from the state of Chiapas, where our chairperson is located, Dr. Oscar Hernandez Amudio. This weekly extraordinary session is very important. It will be about Fanconi anemia, and as every week, I will thank our board of directors, Dr. Oscar Hernandez Amudio, for holding these sessions. And we know, because of the impact we have week after week about the Latin America organization, because we are pleased to have membership of several Latin America organizations, members from Spain and other countries. This is a professional, academic, Latin America hematology, hemostasia, and therapy organization, acronym OLA. I want to thank National colleges of hematology and different associations that follow us across the Americas. Thank you so much for your collaboration every week, as well as resident doctors and professors of schools of hematology, contributing to the success of this session in knowledge sharing for this. As you know, we want to continue with the promotion of continuous education for everybody, and these are the coming events. I would like to invite every organization that would like share sessions regarding hematology, if they can share their contact information and we can share this with you. Our coming sessions from the Mexican Group for the Study of Hematology, we have Hodgkin lymphoma session on April 7. Also, this will be non-Hodgkin lymphoma. April 14, Hodgkin lymphoma. April 21, the celebration of the World Day of AML. April 28, therapeutic strategies for low-risk SFD. And by the end of the month, we will have an event regarding the World Day for Hemophilia on April 17. These are also coming events. We feel this is a way to be in a continuous education pathway in our different organizations and sister organizations from Latin America and Iberoamerica. Another event which is soon to take place in April. This is the Congress for Flow Cytometry, and also in May we'll have the workshop for monoclonal gammopathies. And also we have a coming event on April 5. This is the theoretical practical course on mass sequencing diagnosis of hematological neoplasia with the collaboration of several Hispanic organizations. We are sharing this information across our network. Today we'll discuss aplastic anemia, and I want to thank the Mexican Association of Aplastic Anemia for this event, because we have planned for this for several weeks and months. This is an important topic, as you can see from the speakers presented on the screen: Dr. Sara Frías, Dr. Blanche Alter, and Dr. Carmen Bonfin, who will be our speakers today. Well, we will discuss general aspects of Fanconi anemia and its current situation in Mexico. It is true, it is important for hematologists with children and adult patients. It is important for pediatric hematologists, the approach for hematologists and oncological diagnosis, also hematopoietic cell transplant in Fanconi anemia. And now I will read a brief bio on each speaker. Dr. Sara Frías Vázquez, lead researcher from the National Institute of Pediatrics and Biomedical Research of UNAM. She is a level 3 researcher in our national system for researchers. Her working areas involve the study of the basic defect in the Fanconi anemia, as well as genotoxicity in cancer. Dr. Blanche Alter, senior clinician from the Clinical Genetics Branch, Division of Cancer Epidemiology and Genetics, National Cancer Institute in Rockville, Maryland, United States of America. Her research is focused on genetic syndromes with a propension to cancer, particularly hematological disorders for bone marrow failure. She developed a clinical research program of cancer for congenital syndromes for bone marrow failure. And our focus today is Fanconi's anemia. Dr. Carmen Sales Bonfin, coordinator of the stem cell transplant program of the University from Paraná, Curitiba, Brazil. Her work is based on studying transplant of hematopoietic stem cells for patients with errors in metabolism, primary immunodeficiencies, and syndromes of bone marrow failure. These are our topics and speakers. Today we want to thank the president of the Mexican Association of Aplastic Anemia, as well as vice president, and at the end they will be coordinating the Q&A session. I want to thank each one of our speakers, and at the end we will link together for a Q&A and comment session. Thank you so much.
Hello, good afternoon. Good afternoon. It is a pleasure for us to be in a joint session with the Mexican Association for the Study of Hematology. We thank them for their great support in our joint sessions. Today, it's an important day for our association because we will have 3 important speakers in the knowledge of Fanconi anemia. As you know, in the congenital marrow failure syndromes, this is the most frequent. However, it is a very rare disease, and sometimes it's very difficult to set a proper diagnosis. That is why it is so important that today should focus on these 3 presentations, and we can see what we can do as an association to create a record, a roster of patients. As you will see in each presentation, we have a lot of work to do for our Fanconi anemia patients. I think this is one of the greatest challenges that we have as hematologists, to do more for treating our children. As an association, we have been meeting with the authorities at Congress, our leaders, so these diseases will be included in the group of rare diseases, but we must know our population, and it is important that we work together. You will receive a link through AMAA platforms for sharing your information and some important tips that Dr. Efren Montaño will send you. Thank you so much, Dr. Oscar Hernandez Amudio and Dr. Carlos Martinez Murillo for their support, and of all the board of directors, as well as thank you all of our supporters. And without further ado, I will lead the way for Dr. Sara Frías. She will tell us about the current situation of Fanconi anemia. Thank you so much to our presentations and you all for joining us. Thank you. Hello, everybody. Thank you so much for the Mexican Association for Study of Hematology and the Mexican Association of Aplastic Anemia and Dr. Magdalena Ortiz for inviting us to this presentation, this session. I will briefly mention general aspects of Fanconi anemia, given that our next 2 speakers will speak more about this. Fanconi's anemia is the most frequent cause of congenital marrow failure, and this is a rare disease. It is calculated that we have from 1 to 5 people ill per million, but in Mexico, we do not know the incidence. It would be expected that we could have up to 600 cases given our inhabitants count. Fanconi's anemia will be a disease caused by the mutation in one of 22 genes associated with this disease. These genes are called FANC, and they are numbered from letters A to W. And their common ground is that they work in the metabolic pathway FA/BRCA. In our Fanconi community, well known by its mutations in these genes, we know that 60% of patients have mutation on their FANCA gene, 9% in their FANCC gene, 9% in their FANCG gene, and 22% groups the remaining FANC genes. Their inheritance way, 20 of them are recessive autosomical, 1 recessive linked to X, and 1 dominant recessive. Mutation in any of these FANC genes will lead us to a molecular, cellular, and clinical phenotype of Fanconi's anemia. And this is because deficiency of the repair pathway FA/BRCA, it's called like this because they have shared genes between the breast cancer and Fanconi's anemia. The deficiency in this repair pathway leads to specific phenotypes at cellular and clinical level. This deficiency at molecular level will create a poor response to DNA damage, because in this pathway, under normal situations, this is to oversee DNA replication and to repair some injuries that are deleterious for cells. Whenever we have a functional pathway, we will have an excellent surveillance of the genomic integrity. Each one of our cells has in 46 chromosomes, 46 DNA molecules. These DNA molecules should be open to work by separating their two strands. They allow for replication in order to have cellular division. But sometimes there is some damage in the DNA as the ICLs that have a covalent link of these two strands of the DNA and do not allow for it to work properly. These ICLs, these covalent unions, are repaired by the 22 proteins that code FANC genes. So the FA-BRCA pathway recognizes this injury with some proteins, activates the remaining of the FANC proteins to signal and send effectors that will cut this DNA segment that has the ICL. And let's be aware that if a DNA strand is cut, we will have injury, which is called double strand breakage, which is one of the most deleterious that can happen in the cell. If this pathway is in its normal way, then these breakages, two strand breakages and the remaining of the injury will be repaired by their downstream proteins, which are Fanconi, and these are recognized because they always participate in breast cancer, and these repaired by homologous recombination, a type of recombination that is used to repair DNA and that gives us repair without errors. So if the FA-BRCA pathway is not working, then we need to send the cells to other types of repairs. These repairs join the ends of these two-strand breakages, but in a mistaken way. So a fault repair, meaning that it will not fully repaired, gives us some breakages, meaning that it was not repaired. And we can see this in chromosomes as isochromosomal or chromosomal breakages. But if they do have an abnormal repair, it can join different chromosomes. And this is what we call as radial figures. And these two chromosomal alterations are specific to those patients with Fanconi's anemia. We can recognize these in their cells, so we can make a Fanconi anemia diagnosis. At cellular level, these injuries will provide a series of features that we will recognize because those cells that were not properly repaired or were not repaired at all may go to apoptosis, because it is known that even that from 1 to 4 injuries of this type, the cell is for apoptosis. But if they have this type of alterations where chromosomes are mistakenly joined, then at the cell division, we could have these interface bridges, and the cell may be fragmented with micronuclei, and these severe cellular alterations can lead to inflammation. If this is happening with a cell with Fanconi's anemia, and it is happening in a cellular under continuous division, it will have checkup points, and the cell will need to make a cellular decision whether it goes to apoptosis or it survives, but with chromosomal alterations, which is really bad. So if we choose for survival, the cells will remain, and certainly it happens because we do have patients with Fanconi's anemia, and those surviving cells may eventually go for apoptosis, and this will happen in cell loss in different tissues. One of these, the hematopoietic tissue, and this will lead to a deficiency in the production of all hematopoietic cells. A Fanconi's anemia patient could have some stability in their hematopoietic cells and in all their tissues, but eventually these cells, since are damaged, these cumulative genomic damage may lead to a bottleneck where tissue atrophy can lead to a plastic anemia, and the surviving cells may eventually as well have a clone with selective advantage that will generate a cancer. Recently, a researcher from our group, Dr. Rodriguez, has found that cells regulate the decision to die or to survive with damage through two molecules well known by us, p53, that may lead the pathway to apoptosis, or MYC, allowing survival and a high production of these molecules that will promote cellular growth, but also in our patients eventually could lead them to a clonal selection towards cancer. All of these and many more other things that we are waiting to be resolved will lead us to a clinical phenotype that we know it has three essential components: congenital malformations, pancytopenia, low count bone marrow, and cancer. These disorders may be evident in different stages of the life of a patient. Certainly, congenital malformations will be detectable at birth, bone marrow failure at 7 years, and cancer, leukemia, DMS starts at an early age at 11, and then the development of sound tumors that could be later in their lives. Usually, patients die in their third or fourth decade of life, and I want to make a clarification. In Mexico, we don't have as many adult patients because it is possible because we don't know that they die at an early age or they stop their treatments in the medical institutions. Currently, the National Institute of Pediatrics has linked with the National Institute of Nutrition for follow-up of these patients. Patients have a wide clinical spectrum. We can have patients without any physical data, with multiple malformations, with bone marrow failure, with cancer, or with any combination of these. And this genotype will be patent in Fanconi's anemia patients in different ratios, and it's possible that this is linked to the gene type per patient, to the genotype that is mutated in each patient. Patients have anomalies that have been linked with Bacter association and phenos. I will not talk about this because I am sure that Dr. Alter will talk about this, but with this graph, I want to tell you that I want to show you the wide variability of how frequently these variations of their development is present. We could have up to 80% of patients with any of these alterations, but also we could have a high percentage of more than 20% of patients that do not have any abnormality. Some genes may be correlated with the presence of these alterations and with marrow failure. Other genes with cancer and other genes which are not associated with bone marrow failure and are called VF-alike. In Mexico, we don't have a genotype-phenotype correlation yet because we are only starting with the genotypification of our patients. Now, what about the current situation in Mexico regarding Fanconi's anemia? Well, in spite that we have a wide clinical variability and a wide genotypical variability, there is an important feature in Fanconi's anemia is that cellular phenotype is constant, regardless of the alteration, regardless of the gene, and regardless of the wide clinical variability. Spontaneous chromosomal aberrations are present in these cells. So for a long time in Mexico, back in the 80s, collaborative work of Genesis, in particular, Dr. Alessandra Sandoval at the National Institute of Pediatrics, along with hematologists as Dr. Paredes and other specialists, they began with cytogenetic diagnosis of this disease in the 80s, mid and late 80s. After these years, we started the work of spreading this knowledge so Fanconi anemia will be known, and also that we could establish a diagnosis. So we began participating in different sessions, congresses, workshops, more than 200 across our country. So we became a reference center for Fanconi's anemia diagnosis for our country. To date, we have had diagnosed 170 patients, and an approximate number of studies that we have conducted is 1,300. We have expanded this dissemination in scientific journals. We have more than 29 scientific papers. We also are helping our scientists to have professional development. We have tutored more than 32 dissertation works, and we have participated with more than 150 works. And with this, we have shared our knowledge regarding Fanconi's anemia, and the response has been excellent. This diagnosis is not done only by us. We know that other centers of our country do that, but they are very few. We need so many more. We know that we have a large population of diagnosed patients in the state of Jalisco, and also in the state of Tabasco, Puebla, and Nuevo León, and in some other entities, we know that they have molecular diagnosis, but in a lower number. At the National Institute of Pediatrics, in the cytogenetic lab, what we do is cytogenetic diagnosis. For each sample that we receive, we have a positive and negative control. So we have both controls and that of the patients. We have 6 different culture types, and we select 25 cells, and we analyze their chromosomal level, and we detect the frequency of spontaneous and induced aberrations. These are induced with deoxybutane and myomycin, and they detect these bonds with, and the diagnosis is not because of the reaction of one agent's exposure, because in the FA-BRCA pathway, a subject could have this level of aberrations. No, diagnosis is given by the reference between a healthy gene and an affected gene. Usually we have between 5 and 10 times fold the number of chromosomal aberrations, and usually we use the epoxybutane because this difference is intensified, although there could be more aberrations. This diagnosis is expanded then for karyotype with G-bands and FISH in bone marrow cells in positive patients, because this is a yearly surveillance recommended by FAO and by the World Foundation of Fanconi's Anemia. So we do this karyotype in bone marrow without stimulation. So those cells that are undergoing natural division are analyzed, and these are karyotype of highly diagnosis difficulty and scarce growth. But we could find in these karyotypes multiple alterations that could be non-clonal and clonal, numerical and structural. This patient only had 4 normal cells. All the others presented chromosomal alterations, and non-clonal alterations are important because they show that cells are going on a specific pathway towards a malignant clone. So we must do this surveillance, and in fact, this surveillance in Fanconi's anemia could be done more efficiently because there are specific chromosomal alterations that are not frequently present when it is a non-Fanconi's anemia. These are 1q, 3q, monosomy 7, and deletion 7q. These can be identified in this karyotype, but also we can do this in interface cells, facilitating the location of these features. So we can identify a good number of cells where I am showing you the probe to define if there are some alterations in 3q27. We can see a regular cell, a cell with a breakage, because we can see that this probe shows ruptures, or when we have a triple fold or a duplicated cell. So in order to oversee chromosome 7 in a hyperphase, we place a probe from centromere of 7 and the segment of our interest. So we can see a normal cell, a cell with a partial deletion, 7q, and a cell where is completely missing chromosome 7, like this one. We can use this because patients should be overseen at a cytogenetical level, because this is an important tool to decide if a patient is in the path for neoplastic transformation. What we have seen is that the frequency of non-clonal and clonal aberrations according to the patient's age varies. Here is a sample of patients where they are ordered by age: 7, 8 years, 9, 11, 12. up to 18 years of old. And what we have seen in light blue, we have non-clonal alterations, is that all of them have non-clonal alterations. However, on the first years of life, their number is lower, and then they increase and change the pattern to clonal alteration. So as you can see, these older patients, 15, 16, and 18 years, have one, and some of them two clonal alterations. So this type of surveillance, it's important because we can follow up and it's not costly. What we need is human resources in order to help our patients. Genotypification of patients is important as well because we can detect which is their mutated gene. At the cytogenetics lab, we will genotypify our patients. We began doing this 3 years ago. And we follow MLPA, NGS, microarrays of high density and Sanger sequence methodology. We have the collaboration of several doctors. So our findings in 21 patients, and this is their spread in this pie chart, is that 52% of them have mutations in FANCA, 10% in FANC-B, 14% FAN-CC, 10% FAN-CF, and 14% in FANC-G. This is according to the literature. And I want to mention that we started to study this mutated gene with cellular fusion in order to find which is the complementary group, trying to see which is the complemented gene. And with Berta Molina and Carmen Esmer, and we found one patient with FAN-CC and 9 patients with FANCA. So we are following according to what is reported in the literature. Also importantly, in Mexico, we have found 2 founding mutations. One in Tamaulipas, gene FAN-G at a Mennonite community, and another founding mutation of FANC-GC. The first one was FANC-C gene. This is a Mixe community that is located in the state of Oaxaca. This is important because these are communities where we need to find our patients with Fanconi's anemia because their frequency should be higher. Now, who refers patients with Fanconi's anemia coming to our institution? Well, 62% of our patients are located in the states of the center of our country, only 7 states. And of course, we know that there should be patients in every state, but we only have patients coming from 12 states. So a similar number of states have not referred patients to us yet, trying to find or diagnose Fanconi's anemia. And it is not that there are no patients. Rather, we have no access to them because there is no diagnosis suspicion of Fanconi's anemia. And we also know that there are other medical institutions with FA patients, certainly some of them in the state of Jalisco, but so far we have not had access to them. I want to say then how important it is to say that in our country, we hope to find links to each institution so we can have access to these number of patients that are suspicious to have Fanconi's anemia. We began with this diagnosis around 20 years ago, and we have data collected for over 20 years. What we can see from 1999 to 2009, the diagnosis has had an average of 5 patients per year, but from 2010 to 2019, with an increased number of patients, we only diagnose 10 patients per year. This means that we have more patients for study, but that the diagnosis suspicion is done better. And this means that we are advancing in the interest of the physicians, mainly hematologists. I will say a few words regarding this because whenever there is a good diagnosis suspicion, we can move forward discovering or finding our Fanconi's anemia in Mexico. And as I have said, we can expect up to 600 patients in Mexico. In our center, we have 155 positive mosaics, and we believe that in other entities, there could be several more patients. So we believe that most patients in Mexico are underdiagnosed. Now, origin by institution referred to us for a study is variable. As you can see, most of them come from our own institution, the National Institute of Pediatrics. Dr. Lopez, Monsiváis, all hematologists are experts in this diagnosis suspicion, and institutions from the Mexican Institute of Social Security, other institutions as ISTE, and those presented here in the slide refer patients to us for their diagnosis. Now, the ratio of patients with a positive diagnosis of FA varies around 13 or 12%. There are some others, like the Children's Hospital in Oaxaca. They are great at identifying because 42 of their patients have turned out to be positive patients. So, which are our takeaways? Which is the information that we can obtain from these patients? In the past 20 years, we have had 155 positive cases out of 1,200 patients, but without too much information, because from all the applications of a study, 58% do not share, which is the reason for their suspicion. In those positive cases, this percentage is no different. 62% do not have a specific reason for suspicion. So the information that we have is that they are referred due to malformations, hematological alterations, or because they have a relative that is also affected. But all this is a gray area that we should salvage in both groups. So we don't have data of most of the patients that we have diagnosed across all these years. As for healthcare, most of Fanconi's anemia patients in Mexico, they are seen at the National Institute of Pediatrics, 40%, but third level medical institutions in Mexico do provide care to these patients. National Medical Center La Raza, Siglo XXI Medical Center, Civil Hospital of Guadalajara, 20 de Noviembre, Children's Hospital in Mexico, and other private and state medical facilities. Healthcare usually includes laboratory analysis, medications, transfusions, surgeries, dental care, infections control, and genetical advice, which if possible, the attention is multidisciplinary, but many patients are not members of this type of institutions and they seek their healthcare in their communities. Also, we have made a lot of progress in the bone marrow transplant, and as we will see later, presented by our guests, you will see that this is a truly efficient way to provide care for Fanconi anemia patients. However, even when we have more than 30 units of bone marrow transplant in Mexico, not all of them are doing this for Fanconi's anemia patients. We can say that in our institution, Doctors Laya and Lopez perform bone marrow transplants for so many years now. Dr. Inés Montero and other doctors do this at IMSS with bone marrow transplant, but actually not many of these centers can provide care for Fanconi's anemia patients. Of course, we must consider that whenever a transplant needs to be paid, the expenditure, if paid by each family, is catastrophic, and because we know that they do have limited medical resources and they do not have healthcare at no cost. So what are we doing to improve these conditions for these patients? Well, first, we are creating a formal record of patients. This will be called RAFMEX. This will be to describe and analyze clinical, paraclinical, and cytogenetic characteristics of patients with a suspicion of Fanconi's anemia, because we will focus our attention in those patients that will render positive for Fanconi's anemia, and we will also describe and analyze social, demographic, clinical, paraclinical, cytogenetical, molecular characteristics of those patients that are positive for Fanconi's anemia. Also, the problem with our patients, in general terms, a major problem is that they have not met each other. And we know that if we have alliances, we will move forward at a faster speed. So we are planning to have the first meeting of families with members of Fanconi's anemia. This with the work of several doctors. The venue will be the National Institute of Pediatrics, and this will be the first venue of this meeting. And this will allow patients to relate to other patients, so together they will face challenges for diagnosis and treatment, as well as social. The proper conditions could be established so that the Fanconi's community could create an association, and we hope that the Fanconi community of Mexico will improve their conditions and will have better options to treatment that otherwise will be difficult in a country in development as Mexico is. I want to thank all the working group of the National Institute of Pediatrics, Dr. Carnevale for being a pioneer studying Fanconi's anemia in Mexico, Dr. Monsiváis that has joined our group in order to make of our Fanconi anemia community a well-studied well, and also Dr. Norma Lopez. I want to thank her. Our researchers, Dr. Pelayo, Mayani, Flores, and our residents Marisol González, Mari Carmen Ismer, and Rocio Rios. Thank you so much.
Thank you very much. I thank the organizers for including me. I am sorry we are not in person because I do like to come to meetings in your country. I will tell you several things, some of which will be a repetition of what Dr. Sara Frías said. So I have no disclosures, and I am what is called an epidemiologist, which is a person who counts things and looks for associations. What I want to do in this talk is discuss and distinguish the inherited from the acquired disorders, compare Fanconi with other inherited bone marrow failure syndromes, of which I am sure there are many in Mexico, but we're focusing on Fanconi, and then talk about complications in FA. So the first important thing when the patient presents with aplastic anemia is to distinguish whether it's an acquired or an inherited disorder. You get a family history, a physical exam. Is it an acute or a slow onset symptoms? What is the size of the red cells? Is there elevation of fetal hemoglobin? And is there early onset of cancer in the patient or other family members? This is a slide listing some of the other inherited bone marrow failure syndromes called IBMFS. And they used to be called benign, but now it's non-malignant. I'm not sure there's any difference. Fanconi anemia is the most common, but all of them share either aplastic anemia, pure anemia, pure decrease in white cells, or pure low platelets. They all have leukemia, primarily myeloid, and Fanconi and dyskeratosis both have squamous cell carcinomas, and diamond blackfan anemia have other kinds of solid tumors, whereas the other disorders don't yet have significant numbers of solid tumors. These are pictures of children with all of the syndromes, and I'll move quickly to show you what they are. This is the Fanconi, and the others have other disorders. And these are adults, and again, they have all of the disorders I've mentioned, but these are the Fanconi, Schwachman, dyskeratosis, and others. The age at diagnosis, I think, was already shown, which is in Fanconi, somewhere between 5 and 10 years of age primarily, although we do have a patient who was diagnosed out here in her 50s, and the other disorders may be older in the dyskeratosis because there are more known adults, and the other two disorders are primarily in infancy. What about laboratory findings? Well, blood counts being low, or red cells being large, or increased fetal hemoglobin are very nonspecific, but they do tell you that this may be a patient with an inherited instead of an acquired disorder. You then go on to do syndrome-specific tests. The chromosome breakage was described by Dr. Sara Frías, and the other known and characteristic tests are listed here. The pathway in Fanconi anemia has an abnormality in DNA repair, dyskeratosis congenita in telomere biology, which are the ends of the DNA of the chromosomes, ribosomes, platelets, and early cell death. Our own cohort, which was published in 2018, was analyzed through 2016. And this just shows you how long it takes to do the proper analyses. You can't just do it in a day. At that time, we had about 150 Fanconi anemia patients and about 400 relatives, which includes siblings and parents, and fewer except for dyskeratosis, where we have more. So overall, we keep track of more than 2,000 people, of whom about between 500 and 1,000 are actually affected, and the rest are relatives. These are what are called competing risk analyses, which is saying if this is the first and only event, what is the cumulative incidence? So in the blue here is marrow failure in Fanconi anemia, shown starting in childhood with an early peak of around age 10. In red is acute leukemia, which seems to level off in the 30s. And the solid tumor is black, and it seems to be continuing to rise with age. The shaded areas are the standard deviations of all of the calculations. And these are the other disorders. And the one that is closest to Fanconi is dyskeratosis congenita. The survival in all of these disorders is really into adulthood. And each time we analyze the data, it gets to be older. So in our population, more than 80% of the patients have reached what in the US is the adult age, which is 18, which means although Dr. Frías, Sara Frías talked a lot about the Pediatric Institute, but I want to point out that a lot of the patients are adults. And so they have to start with their registry in childhood, but then reach out beyond the age group. So we'll focus on Fanconi now. And some of you may be familiar with this diagram of the blind man and the elephant, and their perception of what it is depends on their perspective, what they can feel. Well, I turned that into a Fanconi anemia elephant. And again, all the specialists, some of them are listed here, and their perspectives are quite different because we're focusing on the hematology and oncology, but there are all sorts of other systems involved in Fanconi anemia. It was first described by Dr. Fanconi in Switzerland. This is not one of the boys that he described, because he described 3 brothers who had low blood counts, physical abnormalities, and large red cells that looked like pernicious anemia, which is B12 deficiency. It is not the same as the Fanconi syndrome, although it's the same Dr. Fanconi who described it, but that is a specific renal tubular problem. The Fanconi anemia patients do have a problem with their kidneys, which may be underdeveloped or absent. So this is a typical patient. I've shown this many times, and if you want it for your own talks, it's in something called Google Images. He was about 3 at the time. A chagrined look of why are we looking at him like this? Cafe au lait spots, hypopigmented areas, and non-functional thumbs that were just attached by threads. And this is a cousin who looks very similar. And you think the thumbs are behind the crib, but actually she didn't have any thumbs. And she had a typical face with very small eyes. And both of these children died from brain tumors. And this is an example of a single type of genotype cancer association, because they both had mutations in FANCD1, which is BRCA2. Now, these are pictures of adults. These are twins, monozygotic, diagnosed at birth, because this one was missing the radius and thumb. This young lady looked perfectly well, and if you didn't see her sister, you wouldn't know she had Fanconi. This young lady had aplastic anemia at age 5 and received a transplant and was only diagnosed later on with Fanconi. He couldn't remember, says around 6, somebody told him his counts were abnormal. These young men, as you see, are quite tall. In fact, this man came to me at one of the meetings of adult patients and brought this guy over and said, there's somebody taller than me. This woman had tongue cancer, and she was worked up to be a transplant donor, but she was over 50 at the time. So I think by studying the pediatric patients in the registry, it's a great start, but you've got to move into the adult world as well. And as you see, several of these patients developed cancer, breast cancer or head and neck squamous cell carcinoma. This young man had hypopharyngeal. This person developed aplastic anemia in his 20s and was transplanted. So there aren't very many transplants here. And I'm the height monitor here. These guys are tall because I was closer to all the patients than to them. Now, the Fanconi Anemia Organization in the US has had many meetings of adult patients defined as age 18 or above. That was one of the early ones. This is a later one. Here's another one. Here's the last of the in-person ones. And what isn't in this picture, and I should tell them to put them in, there were half a dozen young children under age 1 crawling around in front of the meeting. And then the most recent meeting was done virtually on screen. So as you heard, this is a recessive disorder. FANC-B is X-linked and FANC-R is dominant. The physical findings are present in about 80% of patients. There's a high risk of aplastic anemia, leukemia, solid tumors. There's chromosome instability, a problem with DNA repair, and more than 22 genes. And this is from Moise Fiesco-Roa's publication. He spent 2 years with us at the National Institute of Health in the US studying the literature cases. And this slide was shown to you with the features of the Vater syndrome, features of the Vater association, features of the phenos, and the letters stand for each of the features, and then a variety of other findings. Now, acronyms mean we try to abbreviate things. So Vactoril, we've been talking about. It started out as Vater, but then they realized there was cardiac, so they threw the C in. And L is for the upper limb because R is for renal, and so we can't use that for the radius. I showed you this picture before. He had several features of Vater, and when we went on and looked at patients in our own cohort who had at least 3 of the 8 Vater features, we then could add the phenos abbreviation. And what we have suggested to our genetic colleagues is that they have anybody who meets the 3 out of 8 criteria for Vater, they should look for some of the phenos. And we found that the combination of these patients had at least 4 of the 6 phenos features, because we think the geneticists are missing some of the Fanconi anemia patients. And we didn't use this Fanconi facies, small eyes, small chin, and triangular face, because all of the patients who had that face had small eyes, and we didn't want to count it twice. So the physical findings described in the literature may not be seen in all patients with FA. There are 5 to 10% who had short stature and some of the skin findings, but nothing else. And 20% of those that we know of didn't have physical findings, which means we're probably missing a lot of people. Some persons without physical findings may in fact be diagnosed at a later age, either with aplastic anemia or with a specific tumor that requires attention. And as we get new genes, we keep expanding the phenotype. So this is a very similar diagram to what was shown. The majority of the patients are FANC-A, but C and G are the most frequent if this is a worldwide picture. And then there are all these little slivers of genes for which there are very few patients. And this particular slice of the pie is the 5% in whom we don't know the gene yet. And I will let the Mexican genetics group come up with that for us. So this is Dr. Fiesco-Roa's diagram for the DNA repair pathway with DNA damage. The upstream core complex, these are the names of the genes, make proteins that have to get together and talk to each other in order to add ubiquitin to the complex of I and D2, and then interact with the downstream complex for DNA repair. And if you look very carefully, many of the genes in the downstream complex, if they're present in heterozygotes, not in the homozygotes as our Fanconi patients, are associated with breast cancer and some with ovarian cancer. D1 BRCA2, S BRCA1, J is BRIP1, N is PALB2, and so forth. So there's very much an interaction between the Fanconi and the BRCA DNA repair pathway. Here's an example of the recessive inheritance pattern. These are the grandparents, each of whom has one normal Fanconi gene and a mutated one. They pass either the normal or the mutated to their own children, and they then pass either all the mutated, here's a Fanconi child, or one of the mutated, these are carriers, or both of the normal genes, and then you have a normal child. And in addition, a Fanconi anemia patient is going to at least have a carrier child if they have a child, because one of their two genes has to be passed on. So the children of a Fanconi have one gene, and the chance of them marrying a carrier of the same mutated gene is somewhere between 1 in 100 and 1 in 180. And so because there are so many different mutations within each gene, we so far, except for candidate populations, have not been able to test the potential partner of a Fanconi patient. The dominant are shown here, although this is a bit of a made up diagram because the dominants that we're aware of are new mutations with normal parents. The X-linked is evident only in the male, but he has to get, and so he may have symptoms, but the females don't have symptoms because they have a normal X gene. So who should be tested? Well, anybody who looks like they should have it certainly should be tested. And what I didn't point out in the diagram, in the figure showing all the adults, is that the second from the right, who's a very short, thin, lightweight individual, didn't know she had FA until she developed tongue cancer. Aplastic anemia patients, they should all be tested. Myelodysplastic syndrome, AML, decreased fertility. Now, we're not saying everybody in a fertility clinic should be tested, but if a short male comes in who has decreased fertility and complains of aplastic anemia, maybe he should be tested. I'll tell you a little more about the cancers in a moment, and certainly the siblings should be tested, particularly because they may be donors for transplant. So what are the tests? These days, the major test you just heard about, the chromosome breakage. In addition, you can sequence candidate genes such as the FANC-C IVS4+4 A to T in Ashkenazi Jews. Nowadays, most of what is done is everybody gets what's called a panel, but the panel may not have in it all the rare genes or the genes we haven't yet found. Or if you have the resources, you can go ahead and do sequencing studies. We start with blood lymphocytes, but we sometimes have to go to skin fibroblasts, and I'll tell you about that in a moment. Chromosome breakage was described, and this is blood production. There's a stem cell that makes red cells, platelets, and a variety of kinds of white cells, or lymphoid cells. That's important because lymphoid cells are the usual test site for chromosome breakage, and they have very long lives. So that can lead to a complication that I'll describe, which is called mosaicism. Now, you all know what mosaic patterns look like. I like to take my trips to visit Israel when I could, because they have a lot of mosaic patterns in a lot of their buildings. You worry about that when the blood lymphocyte breakage test is normal, because it tests T cells, which are long-lived. The skin test may be abnormal, because the skin fibroblast hasn't gene corrected. And this is what gene correction looks like. This is a chromosome from a patient with FANC-A. They have a mutation from one parent at one end of that gene, and the mutation from the other parent may be at another end of the gene. When cells divide, chromosomes and genes line up and talk to each other, and sometimes they can cross over. And then what you have is, in that particular stem cell, a chromosome that is, or a gene that's totally normal, and another that's abnormal. Well, that's like a heterozygote, because only one of their genes is non-functional, or one of their chromosomes. So that can lead to a normal appearance in the stem cells that derive from the cell, in the cells that are offspring from that cell that had the gene correction. So what about complications? We've talked about aplastic anemia. Usually the bone marrow has reduced cellularity. We have leukemia in some patients, and myelodysplastic syndrome, which in older adults has low cell counts and increased bone marrow cellularity. But in the marrow failure syndromes, particularly FA, the cellularity of the bone marrow is actually reduced or hypo. And then, of course, solid tumors and specifically liver tumors. So the most frequent kinds of cancer are just listed here: head and neck squamous cell carcinoma, the tongue and oropharynx, or the hypopharynx or the larynx, leukemia, the vulvar, and skin cancers. The less frequent are esophageal, and we may miss some of those because it's not as easy to screen for. The brain tumors, which I'll tell you a little bit about, enogenital tumors. The age is in the 30s, but it can start as low as 4 and up to the 50s and 60s. And back to the competing risk analysis, which is that if you have a death from aplastic anemia, you may not have lived long enough to get a solid tumor or leukemia. One word about human papillomavirus, because in the non-FA population, that's a frequent cause of oral cancer, particularly of the oropharynx. Well, in Fanconi, and that was, we've studied that. So Cutler's group in New York said that was true. And they found it in 84% of the Fanconi tumors, but it was in a high proportion of the control tumors. The group in Holland found it in some Fanconi anemia patient tumors, but only the gynecologic and not the head and neck. And we did a similar study with different patients. We didn't have a lot of tumors, but we only found it in a patient with GYN tumor, not head and neck cancer. So from our perspective, Cutler and Bhuvnesh Singh will say that it's controversial. I think it's solidified, and anyone who's curious about it, I'll be happy to talk to you offline. Now, what about the effect of transplant? So we looked at our North American survey group who weren't transplanted and compared them with transplanted group from Paris. And what we see is a earlier and higher incidence of tumors in those who had a transplant. Now, we couldn't get anyone else to confirm this, so we did our own confirmation in our latest cohort. And unfortunately, the colors are switched. But the point was, the untransplanted group did have some tumors, but the transplanted group was younger and higher frequency. And I would like to point out the x-axis is the age in years. It's not the duration post-transplant, because the untransplanted group didn't have a transplant. So we start with their birth and show the graphs this way. So what about the untransplanted malignancies in Fanconi? These are shown as the standardized incidence ratio, or the number of observed over expected, after correcting for age and gender and birth cohort. And what you see is that in the untransplanted patients, the highest observed over expected ratio, in other words, compared with general population using the SEER data set, we find that it's the oral cancers, the lip, the gum, the hypopharynx are the highest frequency. However, when we add in the transplanted group, they're very similar, although they're slightly higher compared to the general population in the transplanted group. And there's an addition of some tumors that weren't in the untransplanted group, thyroid and lymphoma. And these may be related to transplant complications. So I want to turn for a moment to the FANC-D1 BRCA2, or the FANC-N-PALB2, because we found in these populations in the literature only brain tumors, neuroblastoma, and Wilms tumor, whereas leukemia, which is present in this group, is also seen in some of the FANC-A patients. What led me to do this was one of our FANC-J patients was thought to have a brain tumor. Well, it turns out he didn't have a brain tumor. He has something going on with a rare central nervous system virus leading to inflammation. But it led me to look in the literature because I didn't remember that FANC-J had brain tumors, and they don't. The one brain tumor in a Fanc-A, they only knew one allele, didn't know the other, and don't have any DNA because I've reached out to them. So it's, as far as I'm concerned, it's exclusive to these groups. And Lisa McReynolds, who works with me, have called these the signal cancers, which are unique to these disorders. So if you see a young Fanconi with these kinds of, any of these kinds of cancers, think of these genotypes. So there is a genotype cancer association here. The ages are shown here for the BRCA2s and the PALB2s, and they're not statistically different, although they seem to be a little younger for some of the cancers in PALB2. The limitation of this study is what's called publication bias, which is we had a lot of trouble finding any cases of BRCA2 or PALB2 Fanconi who were reported who didn't have a cancer. So it's hard to do the kind of study we wanted to do. Now, these are two patients. This young man I showed you, and he developed a brain tumor at age about 3. But this young man, who I last saw at Fanconi camp at 5.5, was well. Now, I don't know what the difference is. They're both BRCA2, although they have different mutations, and maybe it's the type of mutation. So we hypothesized that a null mutation, which leads to no protein, if it was biallelic in both alleles, might be more severe than if they had an underproducing type of gene, but it was wrong. So, so far, we couldn't prove that. But specific to FANCD1, which is BRCA2, or FANCN, which is PALB2, is one or more, a brain tumor, Wilms tumor, neuroblastoma, or any of those plus leukemia in the patient or a sibling. Limitation is, of course, that if you're looking for multiple cancers in a patient, it's predicated on survival after your first cancer. So in the study that Lisa McReynolds did, the most common first cancer was Wilms tumor, because that's the most easily treatable tumor in anyone, including Fanconi anemia. Now, what do we do for the Fanconi? We suggest that they have frequent blood counts, annual tests of all types, and they, even though we don't think the human papillomavirus is causative of their cancer, they are entitled to the vaccine, at least in the US, as much as anybody else. One of the things that we are addressing now is the transition from pediatric to adult patients. Now, the first constraint is that they have to survive pediatrics to be adults with FA. And in some places, the US, the age of adulthood is 18, some places 21. I was visiting, I think, New Zealand, where it was 14 or something, so it varies a lot. When they leave home, who makes the decision? Those who have the Fanconi, their parents, their doctors, how? So this is a field in the US called shared decision-making, where we provide counseling with the benefits compared with the risks to each individual. The family may decide, the doctor makes a decision, and we need more data. And frankly, what we've come up with from a lot of studies is, yes, it helps to have a good doctor, but who decides? The mother. So keep that in mind. There are a lot of different people trying to weigh in on this decision. And this is a picture from the 2014 guidelines book. And this is from the newest book. I'm sorry, it's a little fuzzy. It just came out. It is available online at fanconi.org, which is the website run by the Fanconi Anemia Family Support Group. And they are international, not just US, although they started in the US. But as I showed you with those pictures of the adults, there are some who've come from all sorts of places. So we know that Fanconi is everywhere. We have a lot of good data in the US. I think the Germans have some good data. The people in the United Kingdom have some good data. And I hope the Mexicans will follow soon with some good data, although you have a very heterogeneous population. And let me just add a comment, by the way. The Mennonites that you're aware of are related to Mennonites in Canada. they went south for the winter, which I don't blame them. Okay, so we have a web page. Here's our web page for all of the inherited marrow failure syndromes. I had to go very quickly. Dr. Neelam Giri is the staff clinician. Sharon Savage is the branch chief. Lisa Leithwood and Maureen Risch are the research nurses, and Ann Carr is the genetic counselor. And all of these people have been involved for more than a dozen years. So you have to encourage, Dr. Frías, the young people who in your group who are just starting to do this. They got to hang around for a long time. So, and we have a lot of questionnaires, but they're in English at the moment. But if any of the Spanish-speaking families want to enroll in our study, we do have a nurse who is not listed here named Stephanie, who speaks Spanish and can do the intake for such patients. And that's the end. Thank you very much.
Thank you again for inviting me to present this data. And I will talk about the challenges in the treatment of Fanconi anemia. And this is a personal view from a pediatric transplant physician from Brazil. And my name is Carmen Bonfim. I'm the director of the Pediatric Blood and Marrow Transplantation Program at Hospital Pequeno Príncipe. I have no relevant disclosures related to this presentation. And I think that Magda invited me to talk about Fanconi anemia because we have a very long story with FA. And since 1983, we have performed more than 400 transplants in Curitiba in approximately 387 patients. Approximately half of our transplants are performed using alternative donors, that is unrelated or haploidentical donors. And we also follow more than 100 non-transplanted patients. We are located here in the south of Brazil, in the city called Curitiba. We perform approximately 90 to 100 pediatric transplants a year. More than 90% are allogenic, and more than 90% of these transplants are done with the government money. The patients do not have to pay for the transplant. And this may be a difference, maybe of what's happening in Mexico. So you have heard that Fanconi anemia is characterized by this genomic instability, progressive bone marrow failure, the congenital abnormalities, and this striking predisposition to the development of myelodysplastic syndrome, acute myeloid leukemia, and solid tumors. And it's exactly this genomic instability that Sara and Blanche talked about that is related to this impaired DNA repair and leads to increased chemotherapy and radiation toxicity, and makes it a challenge to do transplants for this population. We know that transplantation is the only treatment able to cure the hematological complications related to FA, and it is indicated before the onset of chronic transfusion or clonal evolution. However, if the matched donor is not available, patients may be treated with androgens with a good but usually transitory response. So although transplantation can cure these hematological complications, we know that because of the genomic instability, transplant preparatory regimens need to be modified, and we also need to screen potential family donors. We know that results are excellent when patients are young and transplanted in a plastic phase from an unaffected matched related or matched unrelated donor. However, the use of mismatched donors is really associated with a worse outcome because of increased risk of graft versus host disease and rejection. And in my point of view, challenges now include prevention and early detection or treatment of cancer, treatment of patients with advanced disease, treatment of adults with aplasia, and the use of mismatched donors. So I will very quickly talk about matched related or matched unrelated donors, donor transplantation. And for these patients, if they are young and in a plastic phase, results are absolutely excellent. In Curitiba, we use 60 milligrams per kilo of cyclophosphamide, and the overall survival is 95% at 6 years. And for the past 10 years, the overall survival is close to 98%. And even for the matched unrelated donor transplant, if you can find a matched unrelated donor in the register, then the results are close to 90%. And this occurred because of patients are being referred earlier to the BMT unit. They also, because of an introduction of fludarabine, better HLA match and better supportive care. But bone marrow is the preferred stem cell source when you do bone marrow transplants for Fanconi anemia. And for this group, no irradiation is needed. So if you do have a patient, a young patient in a plastic phase, you should aim for a survival that is over 90%, especially during the last decade. You do not need to use irradiation. And the major problem you're gonna face is the long-term follow-up and for the endocrinological complications and all the other stuff related to FA, but also the most important one, that is the screening for cancer and other complications related to the disease. So the number one challenge that we have in the treatment of FA in 2021 is really the treatment of cancer. And this is very important because it's a lifelong risk of developing cancer, and Dr. Alter just talked a lot about it. And the most important ones are the head and neck squamous cell carcinoma and the gynecological cancers. It's also very important to read the FAF, the Fanconi anemia research found 2020 guidelines, and this is like very nice explanation about the risk of cancer. We know that the use of irradiation containing regimens and or the presence of graft-versus-host disease may increase the incidence of cancer, and that's why you need lifelong aggressive, very aggressive surveillance for early detection of cancer. In this population, treatment options are very limited, and many complications can be related to chemotherapy and radiotherapy. And that's why in Curitiba, we work with the German group, Ralph and Oynik, and we do the brushes to screen and to detect any suspicious lesions, usually in the mouth. So I put this slide here just to remind you that we need desperately to find new drugs to treat these patients, because if they are diagnosed in advanced phase, then you cannot cure them with surgery, and most of the drugs used are very toxic to these patients. So this is something that it's extremely important to have these new drugs. So the second major challenge that I think is clonal evolution. Here in Curitiba, we follow the guidelines published by Regipe Fodelatour and Jean Solier that was published in Blood 2016. And we analyze not only the cytogenetic and the fish abnormalities, but as well the phase of the disease and the amount of blasts that you have in the bone marrow. And based on that, we do the treatment. So clonal evolution is definitely associated with a worse outcome, survival after transplantation, but you need to be very careful regarding the definition of clonal evolution, especially because many patients, they already have a lot of dyserythropoiesis, and this cannot be called myelodysplastic syndrome. We also know that when you try to give pre-transplant chemotherapy, this is associated with excessive toxicity and prolonged aplasia. And that's why we have recently published as well, together with the French group, this sequential approach using a flag regimen followed by a reduced intensity conditioning regimen that seems very promising for patients that have more advanced disease. However, results after transplantation that were recently published by the European group are still dismal, with around 42% 5-year overall survival and a relapse rate of 40% at 5 years. That's why it's so important to have the technology to make this the diagnosis of myelodysplastic syndrome or acute myeloid leukemia. So the third challenge that I think is the treatment of adult populations. I heard that you have very few adults, and here in Brazil, we are beginning to have more and more adults coming to the clinic. So even though we are a pediatric PMT unit, we treat Fanconi anemia patients up to the age of 44. That was the oldest patient that we transplanted. So they are coming, and they will come as we start to make more diagnoses. And this is a very difficult population to treat, because most of them already have advanced disease when they come to you. And usually they have this hypocellular myelodysplastic syndrome that may lead they take them to the hematologist and then make the diagnosis. So here we just presented the data in 2017, including almost 200 patients with a median age of 23, and many patients diagnosed with advanced disease. And as you can see here, the survival is not the same as the 95% overall survival when you have a young patient in a plastic phase. So the main points of this paper was really to detect that there is a very high non-relapse transplant-related mortality, and that you need to be very careful and very gentle with the preparatory regimens and try at the most to avoid graft-versus-host disease. And when you transplant, because these patients are older, you need to be very aggressive in screening for squamous cell carcinoma. And always think if there are not other therapies that can be given to these patients instead of the transplantation. So the fourth and the last but not the least challenge that we have is that when you do not have a matched related or unrelated donor and your patient needs a transplant, that's when a haploidentical donor may be a good option. We all know that T-cell depletion using either CD34 selection or alpha-beta T-cell depletion is very, very effective in depleting donor T-cells that cause graft-versus-host disease. However, this needs sophisticated and very expensive techniques, and viral infections is extremely frequent. So that's why it became so attractive for developing countries to have the opportunity to use a haploidentical donor with this new regimen to treat graft-versus-host, to prevent graft-versus-host disease, using post-transplantation cyclophosphamide. This is a very inexpensive drug. It's widely available, has easy access, it's less expensive, but there is, of course, a learning curve to adapt this platform to FA. Just like we had a learning curve to adapt this platform, the T-cell depletion techniques to the treatment of Fanconi anemia. I will just briefly talk about two very interesting papers for those who have T-cell depletion available. And we have this work published by Dr. Parinda Mehta. This is a collaborative USA study, including 45 patients with a median age of 8. Most of these patients were transplanted from unrelated donors, not haplos, but unrelated, matched and mismatched. They did a CD34 selected T-cell depleted transplant using peripheral blood stem cells. And it was very interesting that based on the age of the patient, the phase of the disease, they had a risk-adapted busulfan dose, and it's very important also because it does not contain irradiation. And with that, they have a 1-year overall survival of 93%, with a very low incidence of acute and chronic graft-versus-host disease. So we also have, like just a few weeks ago, the group from Italy published the TCR alpha-beta T-cell depleted haploidentical transplants. This is also a very sophisticated technique. They have 24 patients with a median age of 9. Only one patient was included with myelodysplastic syndrome. We have all 24 patients are alive, but here you can see the 3 patients failed to engraft or had poor graft function, and they needed another transplant. Altogether, we had like almost half of the patients had viral reactivation, including a very important viral reactivation with adenovirus that needs very expensive also viral antivirals. So that's why we don't have these expensive T-cell depletion techniques. They are very nice and very important for people that can have. And that's why since 2008, we have been working with the use of adapting the protocol using post-transplantation cyclophosphamide to the treatment of Fanconi anemia patients. So in 2012, we published the first 3 patients, and in 2017, we updated this experience. So up until now, we have used this platform to treat 70 patients, the majority, 63 patients with a haploidentical donor, including patients with myelodysplastic syndrome and acute myeloid leukemia. So to make a very, very long story short, for those who are used to doing transplant, there is this very famous reduced intensity protocol that is proposed by the Johns Hopkins group. And that's where we began. We just decreased the dose of cyclophosphamide in the beginning. And because we still had a lot of complications related to mucositis and acute and chronic graft-versus-host disease, we introduced in the second phase of the protocol the dose of ATG to try to decrease especially acute graft-versus-host disease. We were very successful in that, although we still had chronic graft-versus-host disease, and that's where we come to the third phase of the protocol, where now we are using a dose of fludarabine, a dose of CAMPAF before transplant, a small dose of CAMPAF after transplant. We need to use TBI, and the dose is the same as the group from the dose used in the group from Italy. That's 200 centigrades, and this is followed by 50 milligrams of cyclophosphamide, cyclosporine, and mycophenolate. And with that, we have only the haplogroup with 63 patients. We have a median age of 9. Most of these patients, this was a very high risk group. Most of the patients were transfused. We had the majority in a plastic phase, but we transplanted 11 patients with myelodysplastic syndrome and acute myeloid leukemia. Most of the donors were the parents, and 98% of our patients were CMV positive. Here in the table, you can see that graft failure was observed only in the ATG group. We had 3 patients with graft failure, but none in the other groups. Very rapid and fast neutrophil and platelet engrafting. We had a lot of CMV reactivation, but most of our patients were CMV positive and a higher than expected rate of hemorrhagic cystitis. When we had the deaths, they were mainly related to graft-versus-host disease. That's why if we decrease graft-versus-host disease, we will decrease the risk of death. And just to remind everyone that all patients had failed androgen therapy, and of course, they did not have neither a matched nor a related or a matched unrelated donor. So this is the overall survival curve. For the whole group, the 63 patients, we had 1 year overall survival of 82%. But here you can see in the right that when we added ATG or CAMPAF and decreased the incidence of acute and chronic graft-versus-host disease, the survival of these patients, and this includes 49 patients, was 87% at 1 year and 84% at 2 years. So doing this kind of transplant without ATG or CAMPAF is not recommended at all because of the high incidence of acute and chronic graft-versus-host disease. And when we try to look only for the patients that did the haplo with serotherapy, we can see that all patients with CAMPAF, they are alive, but the median follow-up is only 1 year, while the patients receiving ATG is around 84% with a median follow-up of 4 years. We could not find any difference in survival according to the age of the patient, the type of serotherapy, or the number of previous transfusions. We could see that by giving serotherapy, ATG and CAMPAF, and by increasing the dose of serotherapy, here in the left, you can see that when you give a dose of ATG above 5 milligrams per kilo or CAMPAF, you had less chronic graft-versus-host disease. And more recently, when we knew how to choose the donor, if you choose a male donor and you give more than 5 milligrams per kilo of ATG or CAMPAF, the 2-year cumulative incidence of chronic graft-versus-host disease decreases to 27%. It's very interesting to notice that out of the 12 older patients, we had, with a median age of 23, 11 patients are alive with a median survival of 2.5 years, including 4 out of the 5 patients with myelodysplastic syndrome or acute myeloid leukemia. Out of these 12 patients, only 1 patient died, and this was a 31-year-old patient that had controlled graft-versus-host disease, but died of RSV interstitial pneumonia. when we try to look at this protocol for patients that had advanced disease, and this included 11 patients, the median age was also older, 15 years. We had 4 patients with acute myeloid leukemia and 2 patients with advanced MDS. Most of these patients received some kind of chemotherapy. All of these patients engrafted. We had the same complications as in the other group. And out of these 11 patients, 8 patients are alive. We at a median of 3.5 years after transplantations. And the deaths were related to relapse, graft-versus-host disease, or interstitial pneumonia due to RSV. So in conclusion, I would just like to point out that when you have a patient with Fanconi anemia or any other inherited bone marrow failure syndromes, you need to think exactly as Dr. Alter was explaining about the clinical picture of these patients. You need to know the disease phase, you need to assess clonal evolution, you need to evaluate the use of previous medications when you were working this patient for transplant, especially the use of androgens, the use of steroids, the number of transfusions, and the consequences of giving too many transfusions, that is iron overload and alloimmunization. You need to have this multidisciplinary team before transplant, and especially if you have an adult patient. And you need also to address how this patient lives, if he smokes, if he gets a lot of sun and whatever, and really teach them to do aggressive cancer screening and recommend abstinence from smoking, alcohol, and recommend good oral hygiene and sunscreen, health diet and exercise. And after transplant, you also should keep this same recommendation, but you need to have this long-term follow-up clinic. If you remember that if you have a matched donor, you have more than 90% of long-term survival. So this means that your patients will live longer. And that's something that Blanche always told me, is that you need not only you do not need just time after transplant, you need age. You need to see if your patients get older. And this is exactly what's happening to us. As our patients get older, we are detecting more and more cancer in these patients, especially because, as in Mexico, in Brazil, they live very far away. And most of our patients, they are extremely poor. So you need to have this set up this clinic and to work up everything regarding the liver, kidney, gastrointestinal evaluation. You need to address iron overload, see the endocrinological complication and fertility issues. We have 7 patients that had pregnancies after transplant, so this is something very nice to evaluate. Blanche also told you about HPV vaccination. You need to do skin cancer screening every 6 to 12 months and really work with your dentist to do oral examination and do this aggressive cancer surveillance, because cancer risks increases as patients get older and of course in the presence of graft-versus-host disease. And something extremely important, work together with family association and organize these regional and national family meetings. The Brazilian FA meetings, they gather more than 100 patients, and the last meeting we had more than 50 adults included in the meeting. So this is very important for them. So in summary, timing of transplantation is critical to outcome. Maybe the outcome that we have in Brazil and we may have in Mexico is really different from the developed countries, because patients come with less transfusions and they are more, they are diagnosed earlier. We also know that when we get the patient to the unit, we need to modify, we can modify well-known risk factors. And this, we need to select well the patient and the donor. If possible, we should always avoid irradiation containing preparatory regimen. We should use bone marrow using peripheral blood stem cells. If you do not have T-cell depletion, it's a mess. Your patient will have graft-versus-host disease. And if you use mismatched donors, you should use either in vitro, that is like CD34 selection or alpha beta T-cell depletion, or in vivo T-cell depletion with CAMPF or ATG. Remember that a transplantation will not correct non-hematological manifestations related to the disease, and long-term follow-up is essential. Again, I refer you to the 2020 guidelines that everybody can download from the internet. And most important, Fanconi anemia is a rare, and we need these international collaborative efforts in need to advance the care of these patients pre and post-transplant. So muchas gracias, and I'm sorry for in the beginning that we got a little mixed up, but this is the beauty of having these virtual meetings. We are always like learning, and I like to thank my patients, the family organization, Dr. Pasquini, that is my mentor, all the national, international collaboration, and my beloved, really, really beloved Mexican FA friends that I met because of Fanconi anemia. So thank you all for your attention too.
Good afternoon. I'm Dr. Efren Montaño, Vice President of Aplastic Anemia Association. I want to tell you that besides the sessions where we discussed Fanconi anemia cases or aplastic anemia cases, in general, all the bone marrow failure syndromes, we're about to start a program to support families because, as our speakers said, this is done worldwide, and we have very few projects like this in Mexico to support people who live with a person with Fanconi anemia. Our projects for 2021 are to partner with others. We've talked with the association A Heart for Fanconi. This is led by a patient, Alejandra Tabar. She was treated in the US in May. We are going to start these communications between patients and families. And this is very much needed in Latin America. And as Dr. Sara Frías said, and Dr. Benilde Garcia Moises, we are conducting the registry of patients in Mexico with Fanconi anemia. And also Dr. Benilde Moises suggested to make this registry for adults, since we see patients with myelodysplastic syndrome. Sometimes they have other symptoms, and hematologists, we do not suspect they have Fanconi anemia. We say they are not children anymore, and they were not diagnosed by pediatricians, but we will also study adult patients who might have Fanconi anemia. To this end, we also have the registry of aplastic anemia in Mexico. We would like to remind you that Dr. Ortiz, who spoke at the beginning on May 1st, we have the first session to provide information to families and patients with Fanconi anemia in Mexico. And very soon we are going to give you the link to connect to this session. And we've also worked as an association at the Senate, at the lower chamber, so that aplastic anemia is included as rare disease in Mexico. And therefore, we may have access to more resources, especially economic resources, to treat patients with aplastic anemia. And we invite you to stay tuned to what we are doing in this association. We want to give information to patients with aplastic anemia and Fanconi anemia. Thank you very much. Now we are going to start with the Q&A session. It was really a pleasure to listen to Dr. Sara Frías, Dr. Alter, Dr. Bonfim, and well, we had some technical glitches, but finally, this was a very pleasant session and we learned a lot. And the first question is for Dr. Sara Frías. Are there immunophenotypic characteristics in the altered cells and the clonal cells that can be useful for diagnosis or prognosis? Well, it's very likely that we have these immunophenotypical characteristics, but we do not work with them. Maybe Dr. Alter would like to elaborate on this, the immunophenotype in patients with Fanconi anemia?
Yeah, we usually do flow cytometry. That's what you were talking about, the flow cytometry for these patients, and it's how we can make the diagnosis of myelodysplastic syndrome or acute myeloid leukemia. But not we published like 2 or 3 years ago some analysis of the immunophenotype of these patients with Fanconi anemia, but we usually do not see any big difference, at least that we can detect right now.
So patients with acute leukemia and myelodysplastic syndrome, they have similar features. Dr. Frías, do you think that all patients with aplastic anemia, should they undergo the chromosome breakage test? No, I think it is very important that in patients with aplastic anemia to consider the other characteristics of the phenotype so as to focus the diagnosis properly, because we can't cover all the amount of patients who might present aplastic anemia, but especially it couldn't be convenient. That's why it is very important to take into account the characteristics that can lead to a suspicion, a clinical suspicion of Fanconi anemia. With this, we are going to ensure a successful diagnosis. So the characteristics of congenital malformations are very important in patients who have cancer, the types we've mentioned, but cancer at early ages. Sometimes a cancer can be present frequently in an individual who is elderly, but if it is present in a young individual associated with bone marrow failure, we have to think about Fanconi, or if he has certain characteristics like
so if I may add, I think that we have a different way of thinking about this here in Brazil, like all patients below the age of 18, and if they have or if they do not have a phenotypic or congenital abnormalities or whatever, all patients, they are screened for Fanconi anemia. And we detect at least like 20% of our patients, they do not have any congenital abnormalities. So although it's very, it's very time consuming to do the DEB test for every patient with aplastic anemia, we do not undergo any transplant without doing the DEB test. And even the adult group in Brazil, most of the adults, they go up to the age of 20, 25, and they screen for Fanconi anemia all patients. Maybe this may be a reason as well why we have so many Fanconi anemia patients. I understand that it may be very difficult to do for all aplastic anemia, but here in Brazil, every patient below the age of 18, if they have aplastic anemia, they are screened for Fanconi anemia, even if they do not have any congenital abnormality or this long history of anemia that some of the FA patients have.
So this, I would like to reinforce that, which is that in the US, we teach everybody that if there is an aplastic anemia, they should test not only for Fanconi, but also for dyskeratosis congenita. But the appearance, we think is great if they have the appearance, but if they look normal, as I showed you, some of them were taller than me, and you know, I'm short enough, I could have FA, but I don't, I think. At least not at my age. I would be the oldest. But so we do teach to test everybody because the management, so if they're going to go to transplant, the transplant modality is different if you know they have FA or dyskeratosis than it is if you know they do not. But we are sort of a more heavily resourced country than some other parts of the world. And so we can only suggest what we think is the ideal approach. And then people have to decide what they can do. We can't all do everything, but if you could do everything, this is what you should do, is the way we teach it. But again, it's very different. And we get very unhappy if someone shows up who could have been diagnosed for FA and is treated inappropriately. Maybe, so for example, in our dyskeratosis population, we have a number of individuals who got immunosuppression. It didn't work, or it worked transiently. But eventually, when we get to the right diagnosis, we can provide the right treatment.
Muy bien.
Very
Bien
well.
mencionado,
Dr. Bonfim was saying that there have been women that after transplant or treatment have gotten pregnant. So what about prenatal diagnosis in these patients?
No. So it's very, of course, they have, because they are small, they may have more problems during pregnancy, and they have what we say a very narrow window of opportunity. So most of the patients that got pregnant, they got pregnant between the age of 18 and 22. I'm not telling that we had patients at the age of 28 that got pregnant without any artificial insemination, nothing like that, natural pregnancies, but they may have some problems related to birth because of the small pelvis that they have. But most of the children, they are perfect. They do not have any problem related to Fanconi anemia, of course. And they are like really big children compared sometimes to the moms. And it's kind of interesting to see those very small women carrying like those normal babies, but they look so big to them.
So we have published on this on more than one occasion, which is, and it started when one of my patients called me up. She was 18 years old, said, "Dr. Alter, you said I couldn't get pregnant." I said, no. I said, your chances were reduced. So she went on to have 2 children. But my concern about the women with pregnancy, and it's hard to counsel them with this, is that by the time their child is 10 or 15 years old, they, the mother, may have developed a cancer. And, that's what we have to contend with. But that was why I was joking at the last in-person adult meeting. There were literally 6 adults out of maybe 60 who brought their children. And we were joking that now the Fanconi Anemia Fund has to provide childcare at their meetings, but not for the virtual meetings, of course, only when they're in person. So, but my real concern with the first paper, and it hasn't changed, is that mother has to enjoy that child as long as she can. And we can't tell her that it may be shorter, because by the time the child is older, maybe we'll know what to do with the cancer or the leukemia or whatever has developed. And it's not just the transplanted women, it's the untransplanted as well. The other concern I had, Carmen, it's interesting that you mentioned it, is we all thought the mothers are small, therefore they'll have problems. Those kids come out fine. So I don't know how, but they do.
And something very important also to remind is that up until now, we have never, ever seen a male Fanconi anemia patient who has, been father of a child. They are at least, we have not tested everyone, but because some of them, they do not want to be tested. And sometimes we even have children, but we do not propose them to be tested. But usually they are infertile. We have never seen, I don't know you, Blanche, if you have seen a male patient that is.
So at the last adult meeting, there were several men who said, "Here is my child." And the problem is that although we as scientists might be able to determine whether that's true, unless they volunteer for it, we're not going to do it. So so I don't have a good answer for you. I do have, in my experience, a couple of men who I'm pretty sure were actually the father. But again, without the proper studies, which we all know how to do, but nobody wants to do, we can't answer that question. So there is reduced fertility, and I've certainly had male patients who were diagnosed because they developed MDS or aplastic anemia, and they gave a history of having to adopt a child. So, but this is very anecdotal, and as scientists, we may never know the answer.
Yeah, we do not want to, to disrupt the family, but the 2 times that we did that, the patient was infertile, and the marriage broke because it was.
Well, that's the point.
Yeah, but not because we wanted to do this, because the patient wanted to know if he was fertile or not.
Well,
And
none of our male patients have asked us yet. And we don't offer. But it's a good.
No está bien.
Algo que podría ser importante, probablemente.
Something that could be important regarding the question about prenatal diagnosis. It's very difficult to find another carrier of a mutation in any of the genes of Fanconi anemia, but if the marriage is related, maybe it could be a good decision to make a prenatal diagnosis. On the other hand, the Fanconi anemia pathway is very related to the homologous recombination. And this is one of the features of meiosis. Therefore, it is very likely that infertility in patients, especially male, they have many divisions to get to sperm. This is related to the failure in this pathway.
So let me add that one of the things that could be tested for are founder populations. So for example, in the US, there's a large population of Ashkenazi Jewish people, and they have the panel of genes tested before they even have marriages. And so if you know what is, the same thing could happen in the South African Afrikaners with their FANC-A, with the known mutations. But these are rare conditions. And, I mean, for example, in the Mennonites, we know their mutations, and maybe they could. But, it's a fertility question as well. You have to address 2 questions. One is the heterozygote, the carriers. If somebody's a known carrier and marries a known carrier of the same gene, excuse me, there's a risk. But for the patients themselves, it's less likely. And I mean, we have publications, and I'll be happy to share the references if somebody wants them, excuse me. But, these are complications which, frankly, until we realized this wasn't just a pediatric disease, weren't that important. And now we have to start thinking about them and counseling them. And I frankly, maybe you, Carmen, have looked in the latest guidelines book more than I have, because I haven't looked to see what it says there. So be happy that it becomes, yeah, I have one of those too, but I haven't looked at it. These are problems we didn't have 10 years ago. So in a sense, they're good problems.
Muy bien.
Very well, Dr. Bonfim. Which one do you think is the best conditioning regime in patients with Fanconi anemia?
If you are using the
Bueno,
haploidentical transplantation with the post-transplantation cyclophosphamide, then you need to use this regimen that we propose, because we took like more than 10 years to come to this regimen. So we use, I can, like, if you send my email, I also can talk to the physician that asked, but we usually give 150 milligrams per meter square of fludarabine. We give TBI 200 centigrades and CAMPAF before transplant, that's all. And then after transplant, we give a total dose of 50 milligrams per kilo of cyclophosphamide. And this is a dose that we very much used to give because we have transplanted more than 100 patients using 60 milligrams per kilo. So in this protocol, we give 50 milligrams per kilo, followed by cyclosporine, mycophenolate. It has to be IV mycophenolate, because Fanconi, they have a lot of mucocytes, and if they take the pills, because we also did not have the IV formulation, they cannot swallow, and then they do not absorb, and then they have more graft-versus-host disease. Of course, they are not having a good immune suppression. So this is what I consider a very good regimen. If you have like the T-cell depletion, then you should follow either the busulfan-based protocol, but then you need to have busulfan levels for Fanconi anemia. When you try to give busulfan, you need the levels. And if you're going to use the alpha-beta T-cell depletion, then it's the same: cyclophosphamide, fludarabine, rabbit ATG, and then they need TBI as well. So this is a problem when we have haploidentical transplant. It's very difficult to overcome the HLA barrier without using TBI. And we are not a TBI people here in Curitiba. We hate TBI, but we were unable to take total body irradiation, that's TBI, total body irradiation. We were unable to take it off because when we tried to, we faced rejection. So this is very important.
¿Es posible realizar un segundo trasplante cuando
Is it possible to make a second transplant if the first one failed? Para el trasplante idéntico, para el trasplante
that we transplanted, we had 3 rejection. Out of these 3 rejection, we tried to do a second transplant in all 3 of them, and all 3 died. But in other transplants, for example, when you have unrelated cord blood and you have a rejection, you can save this patient with a haplo. And maybe it's just a matter of numbers, and here Blanche can always talk about that. It's just numbers. We need numbers. It's like we can never say that this is the truth, because it's so very few patients. The busulfan protocol from Parinda, the alpha beta T cell depletion with 24 patients from Locatelli, these are all very small numbers. And so if you have other types of transplant, out of this, in this protocol, 4 patients were rescued after they had failed unrelated cord blood or a mismatched unrelated cord blood. And these 4 patients that were rescued, they are all alive. The only deaths we had were the ones that had the haplo first and then had to receive a second haplo. So this would be quite difficult.
So I just found my copy of the book and I made a note because it doesn't talk about male fertility. And I think you and I, as we go through it, should make notes of what's missing from this edition.
That's very important. And something that maybe we could also talk when we talk about haplos and any mismatched transplant is that at least here in Brazil, we have a very good experience using androgens for these patients. So what I always recommend is that you do not rush to take your patient to a transplant with a mismatched donor without like sometimes a lot of support from your hospital or wherever you do the transplant. You should really try to use androgens for patients that have bone marrow failure if they do not have a good donor. Because if they have a very good donor, then they do very well with transplant. If they have a mismatch, that's why it's a challenge. If they have a mismatched donor, then you should take these patients to experienced centers, and because these are very difficult patients to transplant, they are not easy. They are not easy. And Fanconi anemia patients is not for amateurs. You need to concentrate your efforts.
Carmen, what androgen do you use?
That is so difficult. I don't know what's happening in Mexico, but you know, in Brazil, we first used oxymetolone, and then oxymetolone disappeared.
Right, that's my concern.
We started to use danazol. and because oxalimetalon disappeared. And then danazol almost disappeared again. And now we are trying to give oxidrandolone. But this is something that we do not have a lot of experience. But we have, Blanche, more than 100 patients now taking androgens, that have taken androgens. And we can see almost, we can see response in almost 80% of the patients. So the problem with androgens, in my experience, is that you delay the transplant because this does not cure your patient. You will not cure. Your patients may get older, be older when they need the transplant, but at the same time, and you know, it does not prevent clonal evolution. So your patients may develop clonal evolution, but at the same time, it may give you a little bit more time to become smarter, as John Wagner likes to say. You become smarter, and then you may have better donors in 1 or 2 years for your patients.
Well,
En México,
what we found with androgens is that even those who respond may not have a sustained response. But you're trying to buy time. Sorry, Sarah.
Muy bien.
en México, yo creo que
In
siempre
Mexico, I think we've always had an issue with what medications give us benefits. And I think they are using danazol now, but there are times when these medications based on androgens are missing in Mexico. So I think doctors and patients alike are always trying to get them, but it's hard.
It's a worldwide problem.
sí.
Yes, you're right. Very well. This is the last question. And Dr. Moises Fiesco, Dr. Alter, and Bonfim, which strategy can we apply in Mexico to diagnose more adults with Fanconi anemia?
This is a question from Dr. Fiesco.
Él mismo debe responder.
I thought I trained him not to ask questions that I can't answer. I think the problem is, at least in the US, many patients with aplastic anemia, no matter what their age, their DNA is sent for a panel. And that's okay, because if it finds a Fanconi gene, and the most common are A, C, and G, you got an answer. But it's the ones that are rare. There was a study of one group where they took young patients who they didn't know had FA, who had head and neck cancer, and they screened them, and they didn't come up with an increased number. So I think we're stuck. But I think as the panels get better, at least if they find A, C, and G, you've got 80% of your patients, at least in North America. And it's the rare ones, though, that you may be missing. And they may be the ones who weren't recognized as FA because they never had the physical findings. And their only symptom was late onset cancer, or early onset for them, but not pediatric. So it's a problem. But tell Dr. Fiesco he can email
bien, pues.
me. We'll elaborate.
So in Brazil, it was like a movement. In the beginning, only children. Now, as we detect more and more patients, the awareness of the disease becomes more evident, and everybody starts to think about Fanconi anemia. We are beginning to come, like almost 20% of our patients now are over the age of 15. So this is amazing. And usually they come because they have this very long standing anemia, and that, you know, was treated for many other things. And then they come with this hypocellular myelodysplastic syndrome. So patients with hypocellular myelodysplastic syndrome, that in the beginning, you need to have some features because people will not think about FA, and we do not have access to the genetic panel. So you should try to look at first for these patients, and the ones that may have a lot of toxicity as well. We do not have a lot of patients with cancer because we are a hematology center, so they come because of anemia. So we may have a bias because of that. And we may be missing, Blanche, so many patients with cancer in Brazil because they do not have sometimes the hematological complications of the disease, only the cancer. And when you do the DB test, and Blanche and Sara, correct me if I'm wrong, they may be normal because, because the blood counts are normal. So the blood test may be a negative, that DB test.
Well, so the recommendation looking for mosaicism is if you suspect it and the blood test was normal, then you do the skin. But the problem is if you don't suspect it and the blood test is normal, you quit. Yeah. So you don't have access to panels at all?
We have. If you have money, you have
Yes.
access to everything here in Brazil, and maybe the same in Mexico. Like we have, that's why we are developing countries. The gap between the rich and the poor is so wide, and then you have like top medicine, while you have patients that have to take a boat to go to the doctor, and they take like 3 or 4 years to get to a university hospital. And so we have this panel. Rodrigo Calado is able to do many of the panels. We do all the telomere length with Rodrigo Calado as well. And this helped us to have a lot of diskeratosis and the telomere biology diseases. They do not have the full-blown syndrome, but they have the telomere biology.
So he trained in the US, of course.
Yes, so that's
NIH. But
so
this
that-
is why we.
Muchas gracias.
This is why
Yes.
we've encouraged
Thank you very much.
working with Dr. Frías to find out what's going on in Mexico so we can help to guide what they should do. Sorry.
Creo que planearemos una
I think
sesión.
we're going to plan a session only for Q&A. So you are being congratulated, and Dr. Alter, I hope you send me a book autographed by you, and also Dr. Carmen. And Dr. Oscar Hernandez is going to say some final remarks.
Thank you, Dr. Montaño, our speakers, Dr. Bonfim, Dr. Alter, Dr. Frías. Congratulations. You are brilliant speakers. You have shared a live word of knowledge. And as Dr. Montaño says, I agree, we need a second session to discuss questions. There were many things pending. We learned so much about Fanconi's anemia. Thank you so much for your knowledge, for your time. And Dr. Magdalena Ortiz, thank you so much for contacting us and collaborating. Doctor, the Mexican Aggregation for the Study of Hematology will always support you, support any initiative, and with these brilliant speakers, how could we say no? Thank you so much. Good evening. Have a great evening. Thank you. Bye-bye.